Hi, everybody. My name is Cliff Coleman. I'm really excited to be here today and honored to get to join you. I am a practicing family physician at Oregon Health and Science University in Portland, Oregon. And these days I'm spending about 80% of my time teaching medical students, residents, and other healthcare professionals about health literacy and clear communication practices, or spending the rest of my time researching how to teach about health literacy and clear communication practices. Um, I am going to be talking today about um, uh, systemic ageism and how our failures to produce clear communication practices on a systems level are promoting ageism. And the title of the talk here, how unclear communication creates inequities for older adults, a call to address systemic ageism in healthcare. I'll just apologize right off the bat for breaking one of the cardinal rules of clear communication and putting too many words in the title. I spoke at this conference 2 years ago in 2021 on the theme of health literacy and systemic racism. And if you happened to hear me at that time, you'll certainly hear some echoes of that talk here today, but I'm going to be reframing some of these issues around this less talked about topic of systemic ageism. I don't think anything that you're going to be hearing today is going to be particularly new information, but I do think that framing this topic the way I'm going to today will be new for many of us. And I hope that by developing this reframed way of looking at systems issues in healthcare, it will give us kind of some new energy and new ways to talk about these issues, and particularly ways to talk to people in leadership positions who care about care for older adults specifically. So let me get right into it here. I don't have any conflicts to disclose. I'm going to start right off by just pausing for a moment, and I just want to acknowledge that the talk today is going to be focusing on older adults. I'm going to define older adults as people 65 and over. I don't know, but I'm going to assume that we'll have some people attending today who would identify with that age group. And I just want to acknowledge that for folks who do identify as older, some of the information that I'm going to be sharing today might be uncomfortable to hear, and I think there's a potential in talking about large groups and speaking in generalities to unwittingly present stereotypes, which I want to be careful about. And then also there's a tendency or a potential tendency to other people, and I don't want to be othering people who identify as 65 and over. Particularly when we get into the discussion section toward the end, I'll just ask that we all be mindful of how we discuss this population as we would discuss any group in general terms, being mindful of the fact that that these generalities don't pertain to everyone who would identify as older adults. So with that, I'm gonna, as a communications person, I'm gonna tell you the beginning, middle, and end of the story at the beginning. So there won't be any surprises here. And I'll just present some data points for this. So older adults make up a large segment of US society, about 1 in 6 people in the United States. And this is the fastest growing age demographic in the United States. So these numbers will increase in terms of a percentage of the population over the coming decade. We know that older adults have a considerably higher burden of chronic disease than other age groups. They take more medications than other age groups do, and they use more health services in terms of at least dollars wise than other age groups do. We also know that older adults have the lowest average health literacy skills of any age group of adults, that is. Now, I'm going to make an argument today that the healthcare system in general produces large amounts of unnecessarily complicated communication. And I'm going to show a lot of examples of what I mean by that. But the way that we speak to people and the way that we present written materials to people is not only complex, but it's unnecessarily complex. And we know how to make it easier to understand. We just haven't adopted those practices yet. But this has been tolerated throughout our system at kind of all levels. And a result of that is that we are systematically disadvantaging older adults who, on average, have lower health literacy. The solution that I'll present will be a familiar one, this notion of a universal precautions approach to clear communication to help mitigate these inequities that I'm going to define along age lines today. So the objectives are these three. Describe how health literacy, clear communication practices, and age intersect to produce healthcare inequities. Number two, provide some examples from the real world, and I'll be presenting you some examples from the hospital that I work at. And then to discuss this universal precautions solution as a way of framing an approach that our systems haven't adopted yet, but giving us a conversational tool that we can take to leadership to try to make some change in the places where we work. So the outline to get all that done in our short amount of time today, we'll touch on health literacy disparities by age, some of the implications for older adults. We'll talk about systemic ageism, and I'll show you those examples. We'll frame this idea around universal precautions and what it would take to adopt those as a call to reform. And then the part I'm looking forward to most will be the discussion. If you have questions or specifically questions that you'd like to address at that, please feel free to enter those in. I won't be able to see those during the presentation, but we'll leave time at the end to get to those. All right. So health literacy disparities, right? We know a lot about health disparities. We don't talk as often about health literacy disparities. So this first section will be about that. First, we'll get to our usual definitions, and I think many of us are familiar with these at this point. And I'll use the two definitions that Healthy People 2030 proposed recently. The first being an individual person's personal health literacy, right? Their own ability to get information and understand it. And then really importantly for the topic of our discussion today is the second definition, that organizational health literacy piece, which Healthy People 2030 defined as the degree to which organizations equitably enable individuals to find, understand, and use information and services, right? So as healthcare systems representatives and agents of healthcare, we are the keepers or the gatekeepers of health information. And we get to decide how that information flows from our organizations and our systems, right? And do we produce information that flows in a way that's easy for people to understand? Or do we produce information that's easy for some people to understand and harder for other people to understand? And I think you know where I'm going with this. I'll be making the argument that we're making it easy for some people and harder for others. And by doing that, we're setting up inequities that in the case of our talk today are promoting systemic ageism. So you're probably familiar with this slide, which is representing data from the National Assessment of Adult Literacy, showing that for all age groups, here in this top purple bar, 14% have below basic skills and 22% have basic health literacy skills. And we combine those, we see that roughly a third or 36% of US adults of all ages have really low health literacy skills at baseline. Now I'm showing you this because the next slide we're gonna look at this broken down by age group. So here on the left-hand side of this panel, we're showing the bars are showing average health literacy scores on that National Assessment of Adult Literacy, broken out by age groups. And so we can see there's 16 to 18, 19 to 24, 25 and 39 on up. And what you can see is the averages kind of cruise along around that 250 mark. But then when we get to 65 and over, the average drops down to 214, which is considerably different than all the other age groups that we're looking at here. We can then look at the right-hand side of this panel, and it's now showing those percentages of the population who are falling into the different skill categories below basic, intermediate, and proficient. And again, broken out by age groups. Here's 16 to 18, 19 to 24, 25 to 39, and on up. And we see that it's pretty consistent through these younger age groups, but when we get to 65 and over, essentially the percentages of the population in the below basic group doubles, as does the percentage in the basic group. And so now, instead of being 36% in those two lowest skill categories, we're looking at around 59% of the 65 and over cohort, right? Roughly double the other age groups. So why is this? Why would our older adults be exhibiting lower health literacy skills on average, right? And there's two theories. One theory is that something about the less education in this older adult cohort may have led to these observations currently. And the other theory is that perhaps over time, our literacy-based skills kind of decline with age. And so if we think about the education piece to this, we know that health literacy skills are tightly correlated with educational attainment. And that's true for all age groups, as a matter of fact, but it's certainly been observed for older adults as well. And actually, the current group of people 65 and over in the United States has experienced less years of education on average than younger cohorts currently. So that group was less likely to have finished high school, and they were also less likely to have gone on or completed college. So maybe there's something to this less education in this cohort in their younger lives that's carried on over into later adulthood. The other observation, however, is that literacy skills are highly correlated with essentially all measures of cognitive functioning. And so what we could be seeing here is that by measuring or trying to estimate health literacy skills, we may actually be measuring correlates of cognitive functioning. And so we could be detecting cognitive decline over time with age. And maybe it's both of these things. We don't really know. For the purposes of our discussion today, it doesn't actually matter why we are seeing these differences. What really matters is that they exist. So let's talk about some of these implications. And I'll start with a concept called information overload, which is an area of research. Many of us are familiar with this just from our own lives, but there are people out there researching this topic as well. The information overload is essentially what happens when the amount of information coming in is more than a person's capacity to deal with it at that time, right? So the information is either coming in, there's too much of it coming in, or it's coming in too fast, or it's requiring special attention to certain aspects of it, which makes it harder to attend to other aspects of it. When people research this feelings of information overload, we could go out and we can ask people, in your last medical encounter, what was your sense of the amount of information you were receiving? And what we see is that this feeling of this experience of information overload tends to increase with age. So our older adults are more likely to say that they experience this sensation of information overload when they seek healthcare. Now, we know that adults of all ages have a difficult time remembering the health information that they receive when they have an encounter with somebody in the health professions. And we know from a variety of studies that on average, after, let's say, a clinic visit, on average, an adult is going to remember about 50% of the information that was exchanged during a, say, 15, 20-minute medical encounter. Part of the trouble is you don't know which 50% they're going to remember. Is it the really important stuff, or is it the less important stuff? It really depends on what that person was concerned about that day and what was distracting them and what they were keying in for or listening for, right? The other problem with this is, of the 50% that they do remember, half of that is remembered incorrectly. So kind of in an average scenario, about 25% of the information that was exchanged during a typical office visit is kind of retained correctly and intact by the patient or caregiver when they leave. Now, this can have certainly implications for the ability to recall information later and when it's needed, right? When we go home and we're trying to take care of whatever our problem may be, the ability to recall that information and recall it correctly, of course, relates directly to this. So we think about information recall later on, coming back to information, trying to remember the key parts of it, and we can be informed by a smallish study. It was published in 2012. A group of 56 adults, average age of 80 years, where the researchers wanted to see how health literacy affects a person's ability to recall information after some time has passed. So they measured this group's health literacy, or they estimated their health literacy skills, and they measured what's called their working memory, the ability to put information into short-term storage to recall later. And what they found in this small study was that the health literacy scores actually were independent of the working memory function of it, and people with lower health literacy skills were less likely to be able to remember. So what they had done was they gave these folks a brochure that listed 5 warning signs for stroke, and they asked them to read it, and they waited an hour, and then after an hour had passed, they asked them to recall those 5 warning signs. And what they saw was that independent of their ability, of their memory, people with lower health literacy skills had a harder time recalling the 5 items, which is interesting, and it gets to some really fascinating questions about how we encode information, which is beyond our scope for today. But what it does inform us to some degree is how people deal with written information. In this case, it was a brochure. We can use that idea, and we can think about kind of at a national level what some observations that came out of that National Assessment of Adult Literacy showed. And in an analysis that the CDC put together, looking at those data, they said that about 71% of older adults, this is now older adults here is being defined as 60 and older, but of that group, about 71% had a difficult time using print materials just in general. 80% had trouble with documents that were in the format of like forms and charts. I'm going to show an example of a chart here in a few minutes to help us kind of get our heads around that idea. And then 68% had a difficult time with numbers and calculations, which is getting into this area of numeracy, which I will also show an example of when we start to talk about how challenging it can be to interpret prescription medication instructions. Now, all of this in terms of implications for older adults, and I think these are things that many of us in the audience today are probably familiar with, but we know that these all lead to worse outcomes. We know that people with lower health literacy skills are less likely to receive preventive services. They're less likely to understand their medications and take them as directed. They're more likely to describe their overall health status as lower. They're more likely to use emergency services, more likely to require hospitalization when they do present to care, more likely to be readmitted after discharge from hospital, unfortunately more likely to die of all-cause mortality and cardiovascular disease, particularly in older adults, and are more likely to experience racial and ethnic health disparities. So let's talk about systemic ageism now, and I'm going to do this by showing you examples. First, we'll define it. So let's define systemic ageism as occurring when a rule, condition, or policy or practice that is the same for everyone has an unfair effect on a person because of their age. Okay. Now, this could be used to describe disadvantages that could happen to people based on being younger. But for our purposes today, we're going to be talking about disadvantages that occur based on being older. Now, this is a topic that is not really very widely discussed in the medical literature, surprisingly. The things that we do know about it is that ageism is really widespread. It's all over the place. It occurs in many different aspects of the delivery of healthcare. And we also know that it's really associated with lots and lots of varied healthcare inequities. So why we're not talking more about it is a little bit of a mystery to me. But that's maybe why I wanted to have this conversation today. Now, I want to frame my idea around how unclear communication promotes systemic ageism. So I said earlier that the healthcare system is producing this really unnecessarily complex flow of information, right? The way we talk to people and the written materials that we present with them and the other kind of public health messaging that we put out there. All this flow of information is unnecessarily complicated, and it's sort of emanating from our healthcare system and washing over anybody who's trying to seek services. Now, what does that do? Well, that is going to produce an unfair advantage for people who have higher health literacy, who we've seen now, statistically speaking, are going to tend to be younger. This younger cohort of people are going to be more likely to be able to cope with this complex information that they're receiving, and may more likely to be able to benefit from and use that kind of information. And at the same time, it's going to produce restricted opportunities for people who have lower health literacy. And as we've also seen, that is going to be, statistically speaking, an older or more likely amongst older adults, right? So advantages for younger, disadvantages for older. This is our definition of systemic ageism. Now, I want to highlight this idea of unnecessarily complex because we know how to make health information easier to understand, right? We know how to be able to speak more clearly. We know how to create written materials that are easier for people to benefit from. We just haven't adopted that at the systems level as a priority yet. So now let me just show you some examples of this unnecessary complexity. And I think you'll recognize all of these. I'm going to start with just a short video clip. And I want to say that first off, that it is incredibly hard to find video of real clinicians speaking with real patients without a script that they're using, right? So an actual candid conversation between a clinician and a patient is very difficult to find. Really fortunate to have this example, which is a conversation between this woman on the left, whose name is Kat, who's given her verbal and written consent to be videotaped during an encounter with her doctor, Dr. Mark Taubert. Now, Kat is a woman who's experiencing breast cancer, and she's speaking with her palliative care physician, and they're having a conversation during a virtual office visit here, talking about advanced care planning. What does she want done in the event of changes in her condition? And at the moment we're going to step in, they're talking about, does she want to receive CPR if her heart were to stop? And I'm just going to show you a little kind of a 30-second clip here, and I'll highlight just some of the jargon that's coming out of Dr. Taubert. And I just want to say that this is nothing, not to cast any aspersions on this particular doctor. This is the way we hear kind of all clinicians in general speaking with all patients. This is very typical. So let's take a listen.
Came to my outpatient clinic in Belinda, and he suddenly collapsed, and it was sort of a cardiac arrest situation. Mm-hmm. Then I would get the arrest team, and we would basically make sure that if there was a shockable rhythm, for instance, we'd give you the shocks and take you through the sequences of CPR. How successful it would be, I do not know. I cannot tell. But this is something that you would want considered if it were to happen. Yeah. Okay. Fine. And that's completely fine.
Okay. So you can see there are some jargon terms here that I've listed, right? Cardiac arrest, arrest team, shockable rhythm, CPR. What we don't know, and from this, we can't actually tell from this interaction, is what Kat is understanding and what she's taking away from this conversation. You can see that she's listening very intently, and she's giving him clues that, such as nodding and saying, yes, that is something I would want. But we would have to ask her, what do these terms mean to you, if we wanted to know what she was actually understanding there. Let's look at a written example. This is a results letter that a patient received describing the results of a biopsy in their colon. And I won't read through the whole thing, but let me just read the first paragraph there. It says, "Dear blank, I'm sending you this letter to make you aware that the recent biopsies of the nodular mucosa in your rectum did not contain any abnormalities. Certainly this is good news. My suspicion is that these changes were caused by your previous hemorrhoid surgery." And then it goes on to talk more about that. And so to try to think about this in terms of how do we make written information, easier to use and understand, the first thing I did was I ran it just through a simple online readability calculator, which we hopefully at this point know doesn't really say too much about a person's ability to understand something, but it certainly gives us a little bit of idea of the complexity of the sentence structure, and how much of a barrier this might propose to a kind of an average reader. And so looking at our readability statistics here, the Flesch-Kincaid grade level estimated to be about a 9th grade reading level, and the Gunning-Fogg reading level index around a 13th grade reading level. So 9th to 13th grade reading level, just to be able to read through this thing and understand it the first time a person reads it, right? So we know we can improve this, and we know that the recommendation is to be writing at around 5th to 6th grade reading level. So we know there's some room for improvement here. But then there's also the jargon, right? Things like nodular mucosa, and then further down, heme positive stool, right? So there's that. And the person who wrote this very likely saw themselves as a good communicator, taking the time to make it very clear and understandable in their own mind, and could have been taught to make this much easier to understand. Here's a different example. This is an actual results report. So in our system, patients can log into a secure portal, and they can view their test results, and they can communicate with their team and some of things like that. And this is what a patient, when they logged in, saw in terms of a blood test for a thyroid gland function. So I just want to take us through this and think about how confusing this thing could be, who's going to be able to cope with this kind of format, and who might have a harder time extracting meaning and being able to use this thing. So first thing off, I want to point out is the organization of this thing. Now, if you grew up as an English language speaker as a first language, you were taught to read right to left, top to bottom, right, in rows. But if you try to do that on the page that looks like this, you're going to have trouble, right? You're going to see component results, component, your value, standard range, flag, TSH, and on, right? So what's happening here? Why does this thing make no sense? Well, the person who created this intended this to be a table, not a piece of text, right? But it doesn't present itself as a table necessarily. So first thing we ought to do is show it for what it is. Now, I already mentioned earlier that around 80% of older adults showed some difficulties interpreting things in table format. And so we have to be really concerned about this particular one. Now, I want to go through the individual pieces on this table and just think about how we could make them easier to understand. So the first thing we come to, right, is this large font, component results. component results, we could talk about components, we could talk about like stereo components and other things. I'm not sure why that language was chosen, but I would replace that and say test results or something like that. Now we move down and here it shows up again, component. So I don't know why there's so much redundancy here, but again, we could be clearer about what is meant by this column, right? Test name. We go down below that and we see that the test name here is TSH, which all acronyms are jargon, of course. And so we should at minimum at least spell it out, right? It's still, in this case, thyroid stimulating hormone is still heavy jargon, but it needs to be there. Now, moving over to the next column, we get to your value, right? And so you might say like, well, why are you talking about my values? Could we be more explicit? Your test result to me would be less, there would be less room for interpretive error. And then we can move down, we can see that there's again this redundancy. Your value is repeated twice here, so let's get rid of the second one that's not useful. Now we get to this horrible number, right? 4.82 micro international units per ml. Well, that's not something we can probably do too much about, so let's ignore that for now and move over to the next column. Standard range. Standard range might be okay for someone who's got a lot of math experience, but it's probably not, it could be improved probably for the average person. So we might say something like normal range for this test. Range itself is a numeracy term that people may not be familiar with, but so maybe we could improve on that even further. Again, there's this redundancy factor, like why is the standard range mentioned twice? Get rid of that. And we've got these horrible numbers again down below, which we'll ignore for now. And we move over to the last column, and then we get this out of the blue random term flag. So like, are you picturing a flag waving in the wind or what? What's that there for? Does it mean anything, or could I have stopped reading before I got to that? Well, it's probably pretty important actually. And so we should say what it is, right? This is what your test results mean. Now there's nothing below it, so we don't know what is meant to go here. And so the final thing here is we should actually say the sort of the end result, right? Your test was normal. Give the person an actual answer to their questions. All right. Let me move on to another example. This is a similar situation where this is another test result that a person was able to log into their system and see. And this one's a little more worrisome because the results were probably more important in some ways. And so what we're seeing here are results from a biopsy. This person had a lump in their neck, which was found to be what's called a nodule in their thyroid gland in the front of the neck. And so they had gone in to see a surgeon, and the surgeon had used a needle to take a biopsy of some of the cells there, and this is the report of what they saw. So this person who opened up this test result was worried that they had cancer in their neck. And here's what they saw. First thing was that same thing as before, right? Again, trying to read left to right and top to bottom, it makes no sense, right? Component results, component your value, same as before. So how am I supposed to read all this stuff? Why are these words just kind of all over the place? Now, more concerning, though, was as they moved down a little bit, coming to this message here that said your value, suspicious thyroid nodule, right? So that was very worrisome to this person. Unfortunately, what this is really intended to be was anchored by this thing over here to the left, which says clinical history. Unfortunately, the formatting here is reading top to bottom, which is not natural for a lot of people. And it's really unclear that this information about your value being a suspicious thyroid nodule is related to this clinical history. The intention was that this was the reason why the test was done. The clinical history was that this person had a suspicious thyroid nodule, and that's why they went to get the biopsy done. But the interpretation was that I have a suspicious problem, right? So then moving further on down, we get to some language that was also worrisome to this person. The words pathologic is a concerning phrase. And then lastly, this idea where it came to negative for malignancy. That was also worrisome because of the different meanings of the term negative, right? Inside a healthcare environment, negative is usually good. Outside, everywhere else in the world, negative is bad, right? And so this person was really left with a lot of worry, and we obviously could have made this a lot easier to interpret. Show you another example. This one just I'll leave you with a picture, right? So this is what a person received in the mail in order to do their home colon cancer screening test. All of this material came in a packet, including 3 different sets of instructions, which were similar but different from each other. And they were left to try to figure out how to do this test. Now, moving on to prescriptions. This is a screenshot of 2 prescription refill requests that came to me for a patient, and I just highlight some of the language on these prescription labels. The first one here, this medicine called Eliquis, also known as apixaban, is a blood thinner. And the instructions said to take 1 tablet by mouth twice a day to prevent thromboembolism. So the first thing, so I've circled thromboembolism here as a key piece of jargon, which when I rewrote this refill request, I changed to prevent stroke, which is what the reason for taking this medicine was in the first place. And in a minute, I want to come back to this thing about how this was written as twice a day. The second prescription down here said it was for musculoskeletal pain, excuse me, and I just changed that to back pain because that's what the person took it for. But now I want to talk about how the way we as a system produce prescription instructions that create inequities that are harder for some people to understand and easier for others. So in this really neat study that Terry Davis and colleagues did back in 2009, they took a group of volunteers, 359 adults. They gave them a health literacy screening test. And from that, they were able to categorize people as having low health literacy, intermediate health literacy, or adequate health literacy. So 3 groups of health literacy skills. And then they gave everybody a series of different prescription instructions. They wrote instructions on how to take a medicine, and they wrote them in different ways. So I'll show you 3 different ways that they wrote essentially the same instruction. And they asked people to interpret, how would you take this, or how would a person take this medicine, to see if the way that they worded the instructions made a difference. So here's the first phrasing that they looked at was this take a medicine twice daily phrasing. And when they worded it that way, a whole bunch of people misinterpreted this. This range here, what we're seeing here is 29% of people who had that adequate health literacy skills, the higher health literacy group, 29% of them misinterpreted twice daily. 67% of people with low health literacy misinterpreted twice daily. So what was going on here? They might have been things like, they might have said something like, I'll take one at 8 a.m. and I'll take another one at 9 a.m. And I've taken my medicine twice daily, right? And any kind of variety like that. You can think of lots of ways that would get misinterpreted. So they said, well, let's rephrase this. Let's try a different way. Let's word it as take one every 12 hours, right? That would be, they thought maybe that would be more concrete and easier for people to follow. Actually, the misinterpretation got worse when it was phrased as take every 12 hours. In this case, 39% of those higher health literacy folks misinterpreted it, and 70% of the low health literacy folks misinterpreted take it every 12 hours. So what's going on here? Well, what's going on here is that both of these, twice daily and every 12 hours, are math problems. And I already mentioned, that like 36% of US adults have low health literacy skills at baseline. But we look at numeracy skills, about 2/3 of US adults have low numeracy skills across all adult age groups. And as that CDC analysis of the National Assessment of Adult Literacy showed us, almost 70% of older adults struggle with some numeracy issues. So these math problems are hard for people to solve. They did one final phrasing. They said, well, let's try this one. Let's try take one every morning and every evening. And people did a lot better. Still, 8% of the high health literacy folks misinterpreted that, and 24% of the low health literacy folks misinterpreted it. But those numbers are a lot better than these other versions, right? And so what happened here was they took the math out of the instructions and people did better. So again, we know how to do this. We know how to make things easier to interpret and understand. We just don't do it on a wide scale. I'm going to show one additional example here, and you may have seen these in my talk 2 years ago. These are what's called whiteboards or dry erase boards that are posted on the wall in a hospital room for a patient to be able to see and get engaged with their care. And they say things at the top like my plan, plan for today, etc. They're ostensibly geared at helping engage patients, but the language used on them is going to be more accessible to people with higher health literacy and less accessible to people with lower health literacy. And I'm just run through some of these examples. So this person on the top left over here, the reason for the visit is hypoglycemia, right? But people don't talk about hypoglycemia. They talk about their low blood sugar if they're going to talk about this. This next person's active issues include syncope, right? But people don't really talk like that. They say, I passed out. This person's plan for today and activity are DTV 6 to 8 p, something 6 to 8 p.m. I assume. I don't know what that means. And then 2 PA, and then a C with a line over it, Walker. And what does all this mean? Well, I don't know what DTV means, but I know that 2 PA, that the C with the line over it means with. This means 2-person assist with walker, or that you need help from 2 people in a walker. Moving over, this person over here's plan is to get incontinence care at ALF, which I assume means assisted living facility. This person's diagnosis is FX humerus, R circle side, FX being shorthand for fracture, humerus, the big bone in the arm, and R with a circle around it, meaning the right side or the right arm. Could we just have said broken arm? And I'm going to skip down through the rest of these, but you get the idea. So again, the way that we are communicating is unnecessarily complicated, right? Some people are going to do okay with this kind of communication and be able to figure it out, and some people aren't. And who are those people, and how are they going to, how are those divisions going to fall out along age divisions? Okay, so this brings us to what are we going to do, right? And universal precautions approach is not my idea. It's been around for a long time, and but it has had a difficult kind of uptake. So we're going to now think about it as a solution to this systemic ageism question. Now, I mentioned earlier, we know what the best practices are for clear communication, and 2 of the studies that I've been fortunate to participate in have identified a really robust list of best practices for clear communication. In the first study we did, we identified 32 clear communication best practices. And in the second study, we had health literacy experts from across the country rank order those in terms of importance, which ones we think are the most important. And just looking at the sort of top 8 most highly ranked clear communication practices, universal precautions was listed as one of the main approaches. Now, I'll just give you the brief rationale for why this is useful or why it's needed, and then we'll talk about what it would look like. So we know that low health literacy is super common, right? At least 1/3 of adults at baseline have low health literacy, but in fact, all of us can have low health literacy when we're sick, we're scared, we're hurt, or we're sleep deprived, or distracted by anything, right? We know that from old studies that people really feel ashamed about not understanding, and they go to great lengths to essentially hide the fact that they don't necessarily understand. And so when we were looking at the woman in the video talking with her palliative care specialist, and I was commenting on the fact that we couldn't really tell what she was taking away from the message, she very well could have been smiling and nodding and agreeing with his comments, while inside really having some confusion, misunderstanding, or missing information. We know that we can't tell by looking who's understanding. We know that screening tools are available but are not really appropriate in a clinical environment. And the evidence points to the fact that essentially everybody likes easy to understand information. Even people with high health literacy and high education want clear, easy to understand information. So the universal precautions approach says, assume that everybody's at risk for not understanding or having some confusion at any given moment. And use your clear communication best practices as your default baseline with everybody at every point of contact. And if by doing that, we're going to help support dignity, autonomy, and patient safety. This is not news, I know, to any of you. So here's the call to reform. Here's what I think we need to take on as a system. The first thing is we need to work on training our healthcare professionals, us and those that we work around, right? And what is that going to entail? Well, we know right now from available studies that our current workforce is not demonstrating clear communication habits of those best practices that we know that we've identified. And when I say habits, what I mean is like, do people just spontaneously use these clear communication best practices as their routine? And I think the evidence suggests no. This universal precautions idea does not appear to be being taught in our schools of the health professions in at least a robust way. There's very little in the literature to suggest that this is a strong part of any of the curricula of our schools of the health professions at the moment. So if we were to adopt this universal precautions approach, we would want to base that on a set of core clear communication best practices from those, which could be taken from those two studies I just showed you. In other words, we know what those best practices are. And in order to adopt this kind of training and to build up in this area, we would need our health professions training programs, and particularly the accrediting agencies that provide the accreditation for our hospitals and our training programs to build in and then enforce measurable competencies around these clear communication standards. Now, part of the problem here is that if we're going to try to hold health professions education programs to competency standards, we need to be able to measure those competencies amongst learners. So in my case here at OHSU, working with medical students particularly, we need to be able to quantify how much medical jargon they're using, for example, so that we can know if they're going to meet those competencies. And one of the things that's holding us as a system back right now is that we don't have some of the needed assessment tools that we required for us to be able to know if our graduates are competent in clear communication at this point. In fact, I have a poster at today's conference that's describing a novel approach that we've designed to try to quantify jargon used during in-person, face-to-face medical encounters, so spoken jargon, and do that in an automated way so that we can look at an entire class of medical students this week and then come back and look at them again in a month and see if there's been any change based on what we're trying to teach them. So we need some of those tools. The healthcare system is going to need to step up and take some account and show some accountability here as well, because our learners and our currently practicing healthcare professionals need some incentivization and need some support in order to adopt these clear communication practices. And so are the accrediting agencies like the Joint Commission, who is an accrediting agency for a lot of hospitals in the United States, and there are other accrediting agencies as well. They should set practice standards that assure that clear communication is being delivered, and that it's being delivered in an equitable way, right? Which takes us back to that organizational health literacy notion. The accountability really should be based on observable behavioral outcomes amongst patients, and really not on self-report. So in other words, when our system and many systems in this country go out and talk to patients, we'll ask them questions like, did your nurses or doctors speak to you in a way that was easy for you to understand? And what we see at our system is that higher than 90% of our patients will say, yes, they spoke to me in a way that was easy for me to understand. But we know for sure that a large percentage of those people have misconceptions, misunderstandings, and missing information. And so that kind of question, that sort of self-reported thing, is really not adequate, right? We need to actually see, what did this person take away from this encounter that allows them to go take care of themselves. So I'll conclude by saying that until we've adopted this universal precautions approach, we're going to continue to support systemic ageism by making health information less accessible to older adults. And I'm going to stop there. I'll just review. We've gone through our session objectives of describing the link between health literacy, clear communication, and age as they sort of intersect to produce inequities. We provided some examples of commonly observed communication practices and how those support systemic ageism. And then we've talked about this universal precautions approach. And I will say that all of these slides are referenced at the end if you're interested in looking up those references. And we can now, I think, have 10 minutes for some discussion. And if you will take us back, thank you. All right. So I need to get Ian, can you make it so I'm not sharing this, or I'm not in presenter mode, so I can open up the comments. Here we go. I got them. Okay. All right, so let me go through some of these comments. It looks like there's quite a few here. I apologize. I'm sure we will not get to all of these. I'll try to respond offline to the ones that we don't get to. So just going down from the top here, I see so the first comment is, there's so much focus on what patients remember or recall, but do we have any information on providers giving incorrect information? It seems like there's an assumption that the provider's communication is 100% correct, and any incorrect memory or incorrect understanding is always on the patient. Well, that's a really good observation. And we absolutely see healthcare providers providing misinformation. It happens all the time based on a different understanding of, or different interpretations of the data, et cetera, reading different source materials. So yeah, we don't have any information about that, but your point is very well taken, that I should be careful to frame this less as a patient deficit problem and take some accountability for the way the information is delivered in the first place. Very good point. This next one, our health system is using more and more digital health tools, like the quote unquote component results example from your system's electronic portal, slide 24. Do you have any guidance for how to move into that digital health space without creating more systemic ageism? Yeah, we're moving quickly into that digital space, aren't we? And one of the examples here, and I don't know if other folks have this where they are, is this idea about like open notes, where not only can you go in and see those, poorly formatted results notes, but you can also go in and see your poorly formatted providers' visit notes, right? And the shorthand that they use, and all of the shortcuts that they use to document. And what guidance do I have in that area? Well, we still haven't gotten it right in the pre-digital era, right? In terms of training folks how to be clear communicators. So we should expect that adopting these new digital formats is going to probably magnify our problems until we've addressed this as a system. And so this universal precautions approach would absolutely require us to look very close and hard at the digital formats. So I guess that's a not very satisfying way of addressing that question, but thank you for that one. Next comment or question here is, how does the concept of understandable versus actionable information change as we age? How should providers account for that? Well, that's a really interesting question. how does the concept of understandable versus actionable information change? Well, I guess I don't know there's an empiric answer to that in terms of how has it been studied. But I would just say that in order for something to be actionable, it first has to be understandable. And as I think I've laid out here today, information on average, but if nothing else is done to it, becomes less understandable as a person ages. And so I think we need to lower the barriers to understanding, right? Drop down that complexity to its simplest form in that universal precautions approach as a starting place. I don't know if that's going to get us there all the way, though, especially if we think that if we figure out why older adults will have problems over time, and if that turns out to be related to things like cognitive decline, then at some point we're going to reach sort of a floor where we can't make the information any clearer or easier to understand without degrading its accuracy. So I guess I would just say first we start with the universal precautions approach, and then we sort of maybe need to see what we're left with, and that may not take us all the way for our older population. How are we doing for time? Oh, we have about 4 minutes left. Great. The next question is, could you please comment on font colors and background colors that are more legible for the older population? I heard a light color font on a dark background works best, e.g. white font on black background, like on street name signs. Interesting question. I actually don't know that information as well, but that's a perfect question to pose to the Health Literacy Listserv if you happen to be a member of that. And if you're not, the IHA supports the Health Literacy Listserv, which has got 10,000 interested health professionals sharing experience and information on things just like that. So that's a great question. Thank you. The next one is, does legal community input have any effect on how health information is communicated orally and written? I'm not sure if I fully understand the question. Does legal community input have an effect? I'm not sure if the question is referring to whether or not there's legal liability for making things that are not easy to understand or clear or not. So I may need to have a follow-up item to that one. I'm sorry. Let me move down. The next one, the National Assessment of Adult Literacy is almost 20 years old now. Is there more recent data on whether and how the health literacy of older adults might have changed since? Yeah, the 20 years old. So if you know the history of that one, that one was done in 2003. The one before that was in 1993. So they were doing, the idea was to do them every 10 years. I don't know exactly why it was not done in 2013 or now 2023, but the assumption I think was that the data weren't changing, and so the expense of the survey was considered not to be worth it, and maybe it was also a little bit humiliating to the National Department of Education or the U.S. Department of Education to be seeing that these numbers were pretty static over time. The PIAC data, or our international data, and the acronym is, I don't remember what the acronym stands for off the top of my head right now, but those are international studies looking at literacy, numeracy, and problem-solving skills. And so those are more recent data, although I don't know if it breaks it down as easily to see in terms of the age stuff. So you'd have to go back and look at that one. We've got 1 minute left. I'm going to try to get one more here. Universal precautions are great. Oh, I got replaced. Universal precautions are great, but would it not be better to have a way to customize patient communication and patient compliance with this communication at the individual level. Yes, it would be better to be able to individualize communication for everybody. The problem is we don't know how to do that, and we don't know how to recognize when people are having a hard time understanding because they don't give us those clues. So in generally speaking, a patient will sit and smile and nod and listen very carefully, and then say, no, I don't have any questions, and leave. And then, as I mentioned in the data earlier about how much does a person remember, right? They'll leave remembering 50% of what we talked about, and half of what they remember is wrong. So, but the clinician who was interacting with them had no clue. So, so yes, it would be better. We just don't know how to do it, and we have bigger barriers. And so the universal precautions approach is the most viable approach. And I'm going to have to end there. I so appreciate all these comments, and I wish I could get to all of them, and I will try my best to respond to them offline. Thank you so much for attending today, and I hope you all have a really great rest of the conference. I'm looking forward to it myself. Have a good rest of the day.